Salut, 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 salut. Alors, nous allons continuer. Excusez-moi d'avoir interrompu brutalement l'enregistrement. Alors, nous allons faire simple. Ne soyez pas trop. Ne pensez pas que la prononciation en anglais est difficile, mais pas du tout. Déjà, vous êtes médecin. Un médecin, c'est un intellectuel de haute facture. Alors, les choses vont être très simples pour vous, d'autant plus que pour bien prononcer un mot en anglais, ça ne se devine pas. Il y a deux possibilités, soit que vous connaissez la phonétique, et la phonétique, on apprend l'alphabet phonétique international, soit vous écoutez quelqu'un qui prononce bien et vous répétez juste après, OK? Voilà, nous allons considérer les management, OK? Management, c'est la suite du premier cas. Je vais lire, écoutez comment je lis, et vous allez juste répéter après moi. D'accord? Voilà, ça viendra après. Suivez comment je prononce les mots. If the service were fully dilated and the head, j'aspire les H, below the axial spines, then instrumental delivery, ok, very, ok, les et là, c'est vanille, hein? Delivery by ventouse or forceps. Hood. Je prononce pas les O et L, je dis hood, W-U-D, hood, be appropriate, okay? As this is not the case, then immediate delivery by cesarean section is essential. Cesarean section, c'est un mot que vous prononcerez souvent. Delivery, cesarean section is essential. The important points for an emergency cesarean section are, okay, the important points for an emergency cesarean section are the midwife in charge, okay, theater staff, obstetric consultant, specialist registrar, anesthetist, and pediatrician, okay, should be informed. Should. Okay, vous voyez, les OUL de là revient encore. Donc, les O et L sont silencieuses. OK? Should. C'est comme dans hood. Should be informed. The reasons for the proposed procedure should be explained. Explained. Attention à la prononciation des ED. Ce n'est pas explained, but explained. Should be explained to the woman and informed. Explained, informed, explained, informed. OK? Ici, vous prononcez comme s'il y avait que les D. Explained, explained, informed, conseils, obtained, explained, informed, obtained. Okay? Metoclopramide and ranitidine should be given in case of the need for general anesthetic. Anesthetic. Okay? Anesthetic. Le TH est prononcé soit F, soit un D. OK? Anesthetic. OK? Anesthetic. OK? Intravenous is needed with full blood. Attention, ce n'est pas blood, c'est blood count. And group and save scent. OK? Et you, a attention à TH, a urethral catheter should be inserted. Voilà ici, le ED est prononcé id, OK? Alors, vous allez voir que les ED sera prononcé souvent comme id quand les verbes se terminent par T ou D, OK? Comme ici, vous avez to insert, ou dans le verbe to decide, inserted, decided, ou bien concluded, dans le verbe to conclude. The baby should be delivered within a maximum 30 minutes after the decision, OK? Alors, tous les mots qui vont se terminer par les ION là, attention, ION, voilà, je le prends pour vous, ION, quand vous voyez comme ça, vous devez mettre l'accent ici, vous devez monter ici, c'est ce qu'on appelle accent tonique, word stress, the decision, okay? You have here key points, okay? Les points clés, key points, let deceleration, ION, vous avez vu, Late deceleration in labor are abnormal. Late deceleration in, no, in labor are abnormal. OK? Bon, ici, l'objectif, ce n'est pas vraiment le vocabulaire parce que vous allez apprendre, vous êtes supposé avoir appris ce vocabulaire avant. A fetal, 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 fetal. A fetal blood sample should be taken to confirm. Attention ici, les R n'est pas prononcé. Au contraire, on prolonge la voyelle. Confirm, firm. Okay, should be taken to confirm fetal status before proceeding to an operative delivery. Okay, before proceeding to an operative delivery. Okay, voilà. Alors, on va passer à la diapositive suivante. On est ensemble. D'accord? Let's go to the next diapositive. OK. C'est plutôt un autre cas que je vais encore lire pour vous. A 31-year-old woman is admitted, okay, vous voyez, là vous voyez admitted, vous voyez T-E-D, admitted with contractions, track, ok? Parce que I-O-N, je vous ai dit, quand vous voyez ça, vous devez mettre l'accent tonique sur l'avant-dernière syllabe, contraction, at 40 weeks, c'est un I long, weeks, gestation, parce que I-O-N, ok? This is her, les H, il faut toujours aspirer, dans 80% des cas, vous aurez raison. With, this is her fourth, pregnancy. On ne dit pas pregnancy, on dit preg, c'est un G fort, preg, un peu comme les G de duck, ou dans signature, okay? This is her fourth pregnancy, having had, j'aspire le H, having had two terminations, approximately 10 years ago, and an elective, okay, elective cesarean section. Césarienne élective, elective cesarean section. On peut dire aussi plain cesarean section, OK? Césarienne élective. Section for bridge presentation. Bridge presentation, c'est la présentation du siège, OK? 3 years ago. During this pregnancy, she has had an amniocentesis, okay? An amniocentesis because of a high estimated risk for Down's syndrome. 11, 14-week scheme. However, a normal karyotype was found and subsequent fetal echocardiography was normal. In view of a previous cesarean section, she was seen by the obstetric. Attention encore ici. Comme il y a ik, l'avant-dernière syllabe, vous allez monter obstetric consultant in the antenatal clinic at 28 weeks to discuss mode of delivery. The mode of delivery signifie la voie d'accouchement. Mode of delivery. After counseling, a plan was agreed for a vaginal delivery. Okay. After consulting, a plan was agreed for a vaginal delivery. She was admitted with spontaneous rupture of membranes. Okay, she was admitted with spontaneous. Okay, rupture of membranes. After which she had begun to contract irregularly. Okay, irregularly. The contractions became stronger and more regular over the next 2 hours. After admission, and she requested an epidural. Okay, vaginal examination was performed and the cervix was found to be 4 centimeter dilated, centimeter, okay, was found to be 4 centimeter dilated. The head, la tête, okay, the head, vous voyez, j'aspire les H. The head was in the occipital transverse position. In the occipital transverse position, 1 centimeter above the level of the ischial spines. Okay, les S, on les fait toujours entendre en anglais. Okay, there was a small amount of caput and morning. Okay, there was a small, okay, amount of caput and morning. An epidural was cited, okay? An epidural was cited and in welling, okay, and welling urinary catheter in welling urinary catheter inserted. 3 hours later, the woman reported more severe pain, which did not disappear between contractions. At that time, approximately 200 milliliter of fresh blood was seen coming from the vagina, examination. Okay, let's see here the examination. The heart rate is 105 per minute and blood pressure 105, 105 out of 58 millimeter of mercury. The woman feels warm and well perfused. Perfused. The abdomen is soft and the uterus is also soft but very tender with easy palpation of fetus parts. On vaginal examination, the cervix is 6 centimeter dilated and the fetal head feels high in the pelvis and poorly applied to the cervix. The catheter contains blood-stained urine. Investigations, ce sont les examens paracliniques. The cardiotachograph is described below and shown in figure 2078.1 CTG report. Fetal heart rate initially, okay, vous voyez, 150 par minute with variability 20 par minute, 20 per minute, sudden plunge for fetal heart rate to 80 per minute. Note the deceleration, loss of uterine activity, at time of fetal bradycardia. Alors, je vais aller à la diapositive suivante. Je continue la lecture. Je pense que ça va jusque-là. Cardiotachograph. This is a figure 78.1 cardiotachograph. Alors, you can see some lines going down, going up, and sometimes staying in the same place. Okay. So, what questions? What is the likely diagnosis? Okay. Attention, c'est un chiffre fort. Diagnosis. How would you manage this patient? How could you manage this patient? How, j'aspire le H, could, j'ignore les O et L, would you manage, on dit to manage, ok? How would you manage? How would you manage this patient? What are the possible further complications in this patient? What are the possible further complications in this patient? OK? Voilà. Bon, ici, on n'est pas vraiment pour le vocabulaire. Moi, je suis là pour la prononciation. On va aller à la diapositive suivante qui est au fait la gestion de ces cas. The CTG shows that the contraindication, the contractions have stopped. Okay? The CTG shows that the contraction. Oh, excusez-moi, je cherche le stylo. Voilà, il est là. Je le prends. Okay, okay. Let me change the color. Okay, shows that the contraction have stopped. This can be due to the pressure. Okay, this can be due to the pressure transducer. Pressure transducer losing contact with the patient. But in this case, the combination of other factors and the fact that the uterus is soft on palpation suggests that the contractions really have suddenly stopped. The diagnosis is of uterine rupture, a constant pain, vaginal bleeding, sudden loss of contractions, change in CTG, easy palpation of fetal parts, and hematuria or classic features. Okay, classic features. Uterine ruptures is thought to occur in up to 1 in 200 labors following cesarean section. It is more common when labor is induced with prostaglandins or augmented with oxytocin infusion, but may occur even in an apparently normal labor such as this. Uterine rupture may very rarely occur in women with previous cesarean section, either because of a previous surgery, such as myomectomy with trauma, okay, myomectomy with trauma, bon, myomectomy avec entrée dans les cavernes, okay, or spontaneously. A major risk factor of uterine rupture is previous cesarean section. General resuscitation measure, okay, les mesures générales de réanimation, general resuscitation measure should be commenced immediately, okay? You have large for intravenous access, okay? Full blood counts, coagulation test, 6 units cross-match requested. Intravenous fluid. The emergency theater team, senior obstetrician and pediatrician should be summoned, okay? The woman transferred, okay, transferred to the theater immediately for laparotomy, which may need to be on a general anesthetic, and as the epidural is unlikely to be adequate for laparotomy, within a few minutes, okay? Yeah, within a few minutes. Oh, sorry. To the next part. Let's go to the next part. Yeah, at laparotomy, the fetus should be delivered from the abdomen and the placenta removed. It may be possible to repair the uterine defect. However, if bleeding is substantial, other measures may need to be employed, such as a biliary anesthetic, okay, anesthetic suture, or even hysterectomy. If the uterus is preserved, then any future pregnancies should be very closely monitored with elective delivery by cesarean section at 37 weeks gestation. Complication of the uterine rupture. You have fetal, you can have cerebral palsy from hypoxic brain injury. For maternal, you have postpartum hemorrhage, hysterectomy, and coagulopathy, hysterectomy, and postpartum hemorrhage. Okay, so you have some key points. You have the instance of a previous cesarean section scare can range from a dramatic to a sudden presentation, change in CTG pattern, persistent abdomen pain, cessation of contraction, maternal tachycardia, or hematuria should alert the clinician to the possibility of a rupture. And that is a clinical case where a midwife is concerned about a CTG on the level. The woman is 2 years old and had an elective C-section 3 years ago for twins. After counseling, she decided to opt for vaginal delivery in this pregnancy. She's now 38 weeks plus 1 days gestation and presented to the lab wards an hour ago. She was found to have contractions free in 10 minutes, lasting 50 seconds each. Okay, so there was not reported rupture of membrane. At the time of arrival, at the time of arrival, examination revealed the symphysial fundal height, okay, la hauteur intégrée, symphysial fundal height of 39 centimeters, carefully presentation, and 3 out of 5 palpable abdominally. Vaginal examination remained intact. Membranes with the head 1 centimeter above the ischial spines, occipital anterior position, and the cervix 5 centimeter dilated. She was commenced on continuous CTG monitoring because of the previous cesarean section, which showed an initial baseline rate of 135 per minute, good variability, accelerations, and no deceleration. 20 minutes ago, spontaneous rupture of membranes occur with clear liquid leaking. Yeah, so you can see the CTG is shown in figure 77, 9.1. You can see questions, describe and classify the CTG. What are the possible causes of this CTG pattern? What should be your subsequent management? The CTG shows a baseline of 130 per minute and variability of 15 per minute. There are variable decelerations to approximately 70 per minute, lasting 30 to 19 seconds. Although there are no normal acceleration, there is a shortening before and after the deceleration. A sign of the fetus increasing its heart rate in response to the increased blood flow after the deceleration. This CTG is unsatisfactory because the tachometer is not registering contraction. Definition of variable deceleration. Deceleration that vary in shape, size, and timing. The presence of variable deceleration with no other suspicious features leads to the classification of this CTG as non-reassuring. It's gone. Oh my gosh. Yeah, this is another way of managing. So I may say in this situation, the recent history of spontaneous rupture of membrane indicates immediate vaginal assessment to rule out cold prolapse. Okay, verbe très intéressant. To rule out, c'est exclure cold prolapse, procidence du cordon. To rule out cold prolapse is the cause of the subsequent, the suddenly abnormal CTG. This would be a classical. Okay. This would be a classic presentation for chord prolapse, though the condition itself is very rare. Much more commonly, variable decelerations are caused by chord compression by the uterine wall, or for example, by the fetal hand. If, as is normally the case, the cord is not palpable and the baby is not easily deliverable by instrumental delivery, then further assessment of fetal well-being is required. As the abnormality of the CTG has already lasted 20 minutes. This should be by fetal blood sampling, okay? Fetal blood sampling. In this case, fetal blood sampling gave the following results. You have the pH, you have the pH sits, okay? 7.22 base axis, okay? You have a 1 plus 0 millimole per liter with a pH between 7 plus 20 and 7.25. It is reasonable to manage the woman expectantly and repeat the fetal blood simply in 30 minutes. This was done, and the second result was a pH 7 plus 22. Okay, base axis shows 5 plus 1 millimole per liter. At this stage, the woman was fully dilated and pushing involuntarily, and the baby was delivered spontaneously soon after the sample was taken. In this case, the fetal blood pH was relatively reassuring despite the dramatic appearance, okay, of the CTG. It is possible to avoid cesarean section in such cases with appropriate use of fetal blood sampling. It should be remembered that fetal blood sampling is contraindicated in certain conditions such as maternal HIV, hepatitis, or potential fetal bleeding disorders. Key point. CTGs are classified according to the national guidelines as shown in tables 79 plus 1 and 79 plus 2. Fetal blood sampling can often confirm fetal well-being despite a non-reassuring or abnormal CTG, and thus avoid an unnecessary operative delivery. So these are classification of fetal odds, rates, traces according to national guidelines on electronic fetal monitoring. So here you can just see, I want to read them. C'est according to le Collège des obstétriciens et des gynécologues. Voilà, ça c'est pas bon. Voilà, je vais prendre les derniers cas. Voilà. Et je vais aller, oh, sorry. Je vais prendre celui-ci comme dernier. C'est juste pour vous aider un peu à voir la prononciation des mots. It's like that. Sorry. A 32-year-old woman presents to the labor ward with abnormal pain. This is her first baby after 2 miscarriages. Okay, les fausses couches ou les avortements. Miscarriage. She was trying to conceive for 18 months prior to this pregnancy. Her estimated delivery date was corrected after her 11 to 14 week scan to make her now 40 weeks and 6 days. All pregnancy blood tests and ultrasound scans have been normal. The baby was breached at 34 weeks by cephalic at 37 weeks. This morning shared a make-like decorate discharge, okay, followed by the onset of irregular period type pains, okay, 2 hours, okay, c'est ici où le H n'est pas aspiré, 2 hours ago, she felt a gush of clear, okay, clear fluid from the vagina, and since then pains have become much more severe now, occurring every 4 minutes, lasting for 45 seconds. The baby has moved normally during the day. She had a bath at home and took paracetamol, but is now distressed and has come to a hospital for assessment. Her partner and sister, who are both very anxious, accompany her. Okay, yeah, examination. She's comfortable between pains. Her blood pressure is 129 out of 76 millimeter of mercury and pulse 101 per minute. Surface fundal height is 37 centimeter, and the fetus is cephalic with 2 out of 5 palpable. Speculum examination shows clear with pult, okay, in the posterior vaginal furnace. Vaginal examination reveals the cervix to be fully effaced and 4 centimeter dilated. The position is right occipital-posterior, and the head is 2 centimeter above the axial spine. As there is no fetal caput or molding. Investigation: urinalysis, blood 2 cross, okay, proteinuria 1 cross, leukocytes negative, nitrites negative. What is the diagnosis and what is the appropriate management? This woman is in normal labor, okay? So definition of labor is the onset of regular painful contractions with progressive dilatation of the cervix and descent of the presenting part. Spontaneous rupture of membranes has occurred, but is not necessary for the diagnosis of labor. The woman's observations and examination findings are normal for labor. The dark mucus discharge is a show and is not a cause for concern unless the bleeding is fresh or ongoing. The pulse is almost certainly raised secondarily to the pain. The hematuria and proteinuria are secondary to contamination by the show and liquor. Surface fundal height is low because the head is descended, okay, descended into the pelvis, and because the liquor has been released from the uterus. Management. The pregnancy and labor are low risk uh, 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 in that there is no evidence, okay? There is no evidence of any fetal or maternal disorder that requires late care, okay? Yeah. So the woman should therefore remain under wife care and does not need continuous electronic fetal monitoring. Okay. Oh, I'm a little bit lost. Oh, sorry, monitoring. Okay. I mean cardiac CTG. The fetus does not need assessment for well-being with intermittent auscultation for a full minute after a contraction, at least every 15 minutes in the first stage of labor, and for a full minute after contraction, every 5 minutes in the second stage of labor. Monitoring in low-risk labor, hourly blood pressure, hourly heart rate, for hourly examinations for cervical dilatation assessment for mechanism. Once labor is established, expected dilatation is approximately 1 centimeter per hour. If this does not occur, or if signs suggest that fetal or maternal well-being might be compromised, then medical assessment and possible intervention may be indicated. Key points. Normal labor is the onset of regular painful contractions with progressive dilatation of the cervix and descent of the presenting part. Continuous CTG is not required for low-risk women in normal labor by intermittent auscultation is essential. Voilà. Je pense qu'on a ça. C'était l'exercice juste pour vous aider. N'oubliez jamais que la prononciation, ça ne vient pas comme ça. Il faut prendre du temps à pratiquer, à parler. Et c'est comme ça que vous pouvez relever les choses, hein. La prononciation, c'est pas quelque chose qu'on devine en anglais, mais c'est plutôt des exercices. Écouter, répéter, écouter, répéter. Voilà. Voilà, on va s'arrêter par là. Thank you for being there and bye.